Welcome to Lecture 5. Before we get started with this lecture and the other sections of Lecture 5, I just want to make a general statement. And that is, this section is all about assessment. And in your text, you'll see Murray and Clark make reference to a lot of different testing instruments. Many of them I have no experience with, and I think that would be true for most of my working colleagues who are also working with this population. The truth is that clinics have only a certain amount of money to buy test instruments. And so I'm not going to pretend to be able to talk about test instruments that I have no experience with. You can read their descriptions as easily as I can. Perhaps I can add a comment about a test instrument based on some experience I have that you may not be able to glean, and I'll do that if I can. But mostly I'm going to be talking about tests that I have experience with, and I think that by and large, the tests that I have experience with are the tests that are more common and the ones that you're more likely to see when you get into a hospital setting, a rehab setting, etc. So don't let yourself get overwhelmed by all of the different test instruments listed in the assessment of linguistic function for aphasia, TBI, right hemisphere disorder, dementia, etc. In general, this lecture, because it focuses on linguistic function, I'm really going to talk mostly about and spend most of my time with aphasia, because of course aphasia is primarily a linguistic problem, whereas with TBI, right hemisphere disorder, and to a lesser degree dementia, there are communication problems, but in general they're not due to basic loss of application or problems processing linguistic representations and rules. Okay, so when we get to assessment of cognitive function, you'll see that I spend more time with those populations, TBI and right hemisphere disorder, than I do with aphasia, because of course people with aphasia don't have really significant cognitive impairments. Okay, so that just kind of sets the background for understanding the context of these lectures. So in this short section, we're talking about kind of some of the basics of assessment and case histories, taking case histories, etc. Let's start again with a real scenario, which is the real scenario is you come to work in the morning and consults have been generated since you left work the previous day, and they're patients to be seen and to be evaluated, and some of them have neurogenic communication difficulties. Of course, the first thing we do is go into the medical history, and now most of that's electronic, so we can do that. And of course, I've mentioned before that knowing the medical history, the disease process, if there's any neuroimaging data that shows where lesions are, then that certainly can give us an idea of what types of communication difficulties to anticipate. Assessments are also influenced by the kind of question that the referring physician is asking. Most commonly, the question is just simply like, here's this patient, please diagnose and treat them as you see fit. But sometimes physicians have more specific questions, they may not know exactly what disease process a person has. Nothing significant is showing up on neuroimaging. And so sometimes the question directed towards us is more what is really asking us to do a very precise diagnosis so that we can help the physicians make a differential diagnosis. So that's usually something that happens more with the differential diagnosis of the neurodegenerative diseases, the dementias, right? Because some of these dementias, the earliest symptoms are speech and language. And so, for example, we have primary progressive aphasia. Through my in-depth testing, I may be able to make a statement saying something like, these very early signs of aphasia, I think, are more characteristic of a non-fluent variant of primary progressive aphasia versus a logopenic variant. Okay? So sometimes our questions are very pointed from the physicians, and so we spend a certain amount of time and we orient ourselves in the assessment in order to satisfy that type of request. Also, assessments will be somewhat different based on the setting and the time post-onset. So a consult for someone who's just had a stroke, when we go to see them, really we're not looking to do an in-depth assessment on them because we know they're going to change rapidly. And so a screening instrument may be appropriate just to acknowledge that, yes, there is the presence of aphasia, and here is the basic severity of it. When that person moves to acute rehab, then we may do a more comprehensive evaluation. But there we're really probably focusing mostly on describing the impairments and the severity of the impairments, because a lot of the treatment that happens in acute rehabilitation is stimulation intended to try to restore as much normal function as possible. When we get to the outpatient phase, where patients may be in the chronic phase, right? In other words, it may have been more than a year since their stroke when we're seeing them, and so our focus may be more functional, right? And it probably will be. So, of course, our assessments need to take that into consideration. We don't have unlimited time to assess patients, and so for an outpatient it's been a year or more since their stroke, finding out what's most important for them to work on may help guide us into thinking about what to do with testing. There's a link down here that you'll see for, I'll say, kind of a mock interview. This is an interview with a person with aphasia. Her name is Uma. She's in the book club that I facilitate. And she was kind enough to agree to kind of be a guinea pig and let me do what I would typically do in an assessment. I think you'll see that through talking to her that really the most important thing for her to work on, I think the thing that would feel the most meaningful or the thing that she has the most drive to do is to work on her reading. So even though she clearly has speech difficulties, knowing that I have X amount of time, I might choose to really focus on getting in depth on my assessment of her reading. Now later on, you'll see a video where I do a basic assessment battery with her, and of course that was for your benefit and not necessarily for hers. If I was truly seeing her as a patient, I probably wouldn't have done that, a battery. I would have spent a lot of time investigating her reading because I knew that's what I was going to treat. When it comes to assessing the communication abilities of people with right hemisphere damage and TBI, I think you'll see a recurring theme in the Murray and Clark text, which is a statement something like, there really aren't very many good tests to address this in this population. And that is true. We really don't have a lot of standardized tests that really focus on this particular kinds of communication difficulties that people with right hemisphere disorder and TBI have. As a consequence, I think that SLPs rely more on informal assessment. Language sampling is probably what I do the most of. In other words, engaging my patients in conversations or different kinds of connected speech samples, and then listening back to them later myself and trying to suss out what's going on with that person. So, many of the test recommendations that she makes, I don't think many speech pathologists have a lot of familiarity with those, except for some of the batteries that she mentions. But in particular, she mentions using some tests that are designed for children or in academic settings, and often we don't see hospital clinics or rehab clinics having those tests in stock. Getting back to the structure of the assessment, case history obviously is very important, and most important are the patient's complaints. And the patient's complaints can tell us a lot about what kind of problems they're having, the situations where those problems are exacerbated, the situations where they're able to handle those problems better. Of course, that's really valuable information in terms of thinking about goals. Your authors describe that we should do observations on patients, this idea of, and it's a reasonable idea, watching people kind of in a naturalistic setting as if, we were naturalists. But the truth is we often don't have the opportunity to do that. We could certainly watch someone in an acute rehab setting, but we're not watching them in a natural setting to begin with. They're in a hospital. If we work in a nursing home, we may observe our patients as they're interacting with others during lunch or during some kind of recreational therapy type of thing. Certainly very difficult to do any type of observation with outpatients unless we're doing home health. And home health, I think, is really, I haven't done it personally, but I can imagine, well, I've done a little bit of it, but not enough to really speak about it with any confidence. But my sense is that doing home health, there's a real ecological validity to treating people in their own homes, and it's easier to make observations that truly reflect how people do in their normal settings if we're doing home health. As far as screening instruments go, I think probably most facilities have their own kind of cobbled together screening tool that they use. The Western Aphasia Battery, which there's a link to a copy of the protocol of the Western Aphasia Battery. Found that luckily. If you go to the very bottom, you'll see the bedside version of the Western Aphasia Battery, which is the screening instrument. And something like that can be very handy, particularly if you're a new clinician. The person who was my CFY supervisor and has about 5 years more experience than I do, just as an example, he told me that when he goes in to screen somebody for aphasia right after they've had a stroke, he doesn't bring anything in with him. He just asks them questions, uses the objects in the room to test them. He essentially does it on the fly, and he's done it so much that he can make do an adequate screening. The Boston Diagnostic Aphasia Examination, the BDAE, also has a short form which can be used as a screening tool, and on one of the other pages you'll see a link to the BDAE protocol.